Yes. Popped up a few times for office hours. Thanks for help.
Oh, you're welcome. I hope you were helpful.
Yeah.
Is the kitchen.
That sandwich place looks pretty good. Is that your like go-to sandwich spot?
Probably should be. It actually is very good. Very good fresh sandwiches. And it's like, like 100 feet from where I live.
That what would be dangerous for me?
But my kids don't eat it, so I actually don't eat it. very
Oh, they're
often.
not into the sandwich game.
No, just in front of McDonald's all the time.
Oh.
Have you ever, anybody else been to Foothills Park? I don't think so,
Oh.
no.
I honestly get lost with all the different skate parks names. I'd say probably, but I can't remember.
Okay. It's a very nice, unusual place. But one of the catches is, probably don't have cell phone reception.
Mm.
So everyone needs to actually know where we're going before we get there, because if you get lost and you're there.
Yeah. It's in the
Can't
middle.
find you.
Yeah. Mark a pin on it like a Google Maps and say, we'll go here.
Because I'm not sure either. Or less than 5 times.
All the parks are kind of blended together in my mind.
Susan Weber retiring? Well, what happens after that?
Let's see if the world ends. See if there's another Y2K. No, I think we'll be fine.
Yeah.
Hello.
I'm not actively doing anything right this second, but
I mean, yeah. I think we have a pretty decent chain of command. I
it's
mean,
not a
there's,
surprise suddenly overnight.
No.
There's a planned transition.
Yeah. yeah. But yeah, I think tomorrow is officially her last day.
I say for what?
I haven't heard that.
You know Susan Weber? At some point.
Sorry.
I think she was trying to push
You know
the
Susan Weber is?
duster. It's not was.
Have you used Star Tools?
Yeah.
So
When I send you that link, I guess they're like advertising Duster as like a
she's
thing
the
now.
person
I think they
primarily
have.
behind Star Tools, so she's
on
been
the
at
street.
Stanford for
Was
like
my impression that
25 years or
was.
something.
I think that's.
So Star
really
Tools started in
Or,
2005, and then this
That's the
first
goal. The end goal is.
2008, so it's been around for a long
First
time. It's had
person to
time
sign
to
up.
mature and all that.
I have no idea.
This first to join the
so
great.
they're so happy that you can evaluate.
So OMOP is only the only thing that came out end of 2019,
Okay.
Good.
but Star
Probably
Tools has been around for a
easiest,
while.
you can just join the Zoom meeting.
It was Susan and her
Okay.
team that primarily did this, so she's part of my extended team,
You guys have like.
but I have never worked with her.
Or what I'm saying is,
Okay.
if you don't wanna deal with doggles, just.
Oh, I see, and then just share my slide. Yeah, that makes, I'll do that.
Just mute and
Unless
in your computer.
unless you have, video or anything
Yeah,
special.
this is a planned position, so I think we'll be fine, but.
I usually don't, but now I include a video clip to start the talk now, which is a video. of-
magic.
So we
I
will
do
probably.
You know,
both.
my daughter is
I
asking
do
about you, she's like, when she watched the video of it like 10 times. I
Hey,
also
that's
watched,
cheating.
I also watched the video 10 times and still could not, like, I watched what you handed to her, I watched what she handed back, like,
Well, it's her, it's literally her, right?
I analyzed it, I still don't know how you did it, so.
Magic.
That's what, she asked me,
I
I had
didn't
this
do it,
whole
it was her daughter.
discussion in the car, she was like, is magic real? Like, it's not real, right? Like, how did he do it? Like.
What is magic? Anyway, some unexpected, oh yeah, that's.
But that email of yours, Jonathan, it took me also for a second on April 1st. It's like, wait, what? That was good though.
Unbelievable, huh?
Wait, so will the volume it'll go through here, right?
So the room has a mic and,
Oh, but the
microphone.
problem is that I joined and I'm not, you guys have to give me,
Okay, yes, let me promote you.
you have to promote me.
I see, yeah. It turns out it's like I did some magic for her.
How did
Oh.
this cohort and since
Yes,
you're
she's 6 years old or
doing
something
better
like
than
this.
us,
Prime magic age.
with our
It's actually
innocent
too young?
question about
a little
Star
too young.
Oh,
Well, it's hard
no.
to tell because the whole time she didn't say a word. She didn't even make an expression, just like, oh, she doesn't like it. Or she thinks like, what is this stupid? Who is this weird man like doing this? So I'm like, all right, but apparently after the fact, she kept up, but she was like, I want more magic. So I like, but then she's like so shy, she doesn't express anything, it's hard to tell.
Jonathan, by the way, your April 1st email totally tricked me. I'm so ready to vote for you.
Why did you vote for me?
That's a good one.
Maybe too believable, huh?
Yeah.
I actually probably would have actually applied for that thing. I don't know that I would have gotten it, but I think you had to like fill like a 2-page application, essay. I don't know.
More pressing for concerns.
Who knows, next
Was
year.
that thing real or did you make it up?
It was so real, right?
No, but did you make up the competition?
It was a real thing.
Why didn't you run?
I was considering doing it,
Because he
but
didn't have,
you had to fill out like an
he
application.
didn't want to actually
form.
have that choice to make.
You'd have to kind of like write an essay to like justify like why, I'm
Another
like, oh, my
application.
even then it wouldn't have
They
been
would
like,
have picked you because it would be such a great storyline, like, oh, he's a Stanford professor, like.
yeah, so if they have it again next year, I will probably apply next year, 'cause why not? I think it also was just the lab, it was just very busy, like, wait a minute, even if I get this thing, I would actually have to like leave the university for like 2 months just to have time to
But
do it.
you
It's
have
like, I don't have
sabbatical
time to
time
step
yet?
away. I would, but it's more about, I got too much stuff to do in the lab right now.
You're never not, like, you're always gonna have to.
I need to get promoted first, Roxana, and then I will disappear for sabbatical. Yes. Okay, done, see y'all. Come back next year.
You're going on sabbatical?
That's something. You have to do sabbatical, and if you don't, they take it away from you. That was what my wife's PhD advisor did.
That's what takes sabbatical and just like stay here and like work, and I was like, what are you doing?
That is, it's just, hey, you can't call me for administrative or clinical responsibilities anymore. I just want to be left alone to write a book or something.
It was like writing grants, and I was like, that sounds like a terrible way to spend a sabbatical.
He's got stuff, where he's like gone to Italy and on a course on infectious disease outbreaks or something silly, just as an excuse to do. Or like, we strangled some systems. I have not figured it out yet.
Do you have to show what you did in your sabbatical?
No, it's a sabbatical. You go do whatever you want.
Okay, show.
Use that time to go learn something new. They used to have the time to pay attention.
But why is this?
You just like click on it, play from start.
That's what I did.
Oh, no,
Oh,
escape and,
this is why I didn't want to use my own computer. I need a new computer.
oh
Oh my gosh, it's not going away.
yeah, did you have this, your drama at the DVD
Yeah,
fest or
I
something?
did, because my computer is terrible.
That's weird.
It's not, it's like frozen there. Really annoying, okay.
Well, people are gonna be trickling in for several minutes just grab food, so you got some time to.
So okay, that made it go away, so let me just try again. Right.
Busy with
Anyway.
I just sit on the other side of it.
going.
Everything was the expectation
Is
is clear.
Beamer like all
They love.
here, like in the lab?
There's not for sure about the quality and
Beamer.
it's
It's not taken yet,
Sort of.
Yeah, I think we've heard most of this stuff.
that's fine, I just want to hear in your own words and.
In my own words.
And get a sandwich along the way. There's a bunch of stuff that just came out today, which is super fascinating.
Yeah.
Like a few more papers.
Oh, yeah.
This is actually-
Yeah, I did, I missed it.
One in Lancet Digital Health, one in engineering. Yeah. So 3 papers. Use the program or.
Actually, no, it's probably worth
So
it.
institutions, UC San Diego, workers came out saying, in basket, pointless 22% increase in time to read.
Oh, what?
Completely contradicting the previous paper that he's a co-author on.
Is it because?
There's no other Stanford author except Tosin.
Yeah.
So that's the first. Second,
That was from San Diego?
San Diego, yeah.
But, okay, were there epic authors? No.
So I,
There's a story here.
exactly, so I haven't had time to sort of debug the social network.
Oh, I have to message Condy.
Exactly.
Because Condy told me all these
So
stories.
he's not on it.
Okay, but he'll probably.
But he'll probably know. So second one, Mount Sinai used it for coding, used GPT-4, Llama 70B and a bunch of
I saw
others.
this paper and it was no good.
No good, basically. 40% error rate if you want exact right code, 7 to 10% if you take an equivalent code.
This was BMIR, yeah. I'm pretty sure I peer reviewed that paper, right?
The Sinai one? Sinai one?
I think it was.
Okay, and then the third one is Lancet Digital something from Mass General Brigham. Simulated cancer cases, 28% error rate, 1 fatal recommendation.
Oh my God.
Casey's having a field day with it right now.
This is Russell, he's a postdoc.
Oh, I shared, like, I'm not seeing it. You know, my admin was telling me that she thinks I need a new laptop. And, I was like, no, I've had this one since my postdoc, like I had to be my postdoc, I'm like,
It's fine. It's
I'm
fine.
emotionally attached to it, I have, I know all my.
It's just an object.
I know, but like, it's like, you have to do all the setup and then you have to put all the Stanford stuff and it just takes.
It takes an effort to install.
Oh, I mean, as a PI, let me tell you how much coding I do.
I just did some Python coding 2 days ago. It was like, oh, yeah, we're all have to do with magic though. What have to do with
My students needed something, and the only way to get the information was to like run some old code and then write some new code, and I was like freaking out, I was like, oh god, please don't throw out an error, please still run, because if I ran.
You'll help out. It'll be good.
Pray that past you doesn't
You know,
screw over current you.
Yeah.
Alright, so we're at the four right now. People are still trickling in. Why don't we go ahead and start at least informally to the dive in depth in just a minute. Dr. Daneshjou, we're very privileged to have you here. Go ahead and finish up with the last 5 minute sandwich. I'm gonna do many exciting things. For the people who don't know you, although you've been here in the Stanford community for a long time, maybe over a decade, I think.
Yeah.
Yeah, so, but for the many people who may not know you yet, go ahead and tell us about yourself. What have you been doing for 10 plus years here? You could have been doing something else. Where did you grow up? Where were you born? What brought you to where you are
You want
today?
the full story, like, oh yeah, my parents met in college, no, I'm kidding.
Sure, yeah. Whatever you, whatever was
I was
happening about where you
born
are.
in Texas.
Okay.
I was born in a small suburb. I was an accident, but I was not unwanted.
I'm the same, actually.
At least my parents tell me I was not unwanted. I grew up in Texas. I went to nerd school for high school, the Texas Academy of Math and Science, which was a boarding school for high school students who want to take college classes. I was always a nerd. And then I went to Rice for my undergrad and I studied bioengineering. And one summer, glorious summer, I went to Berkeley to do research. And then I was like, whoa, I want to move to Northern California. So thankfully, despite many people who didn't think it was possible, I actually got into Stanford for med school and came here. And I started working with this guy named Russ Altman, who I saw give a talk in one of my seminars. Still have the actual first email. He seems a little like uncertain in the email. Anyway, I ended up doing a year of research with him through the HHMI program. And then I transferred into the MD PhD program, which is.
So you didn't initially plan to do that?
No. Yeah, that was a fun conversation with everybody. Yeah, I'm gonna like stay in school a lot longer. And then I went to dermatology resident. So I actually left Stanford for a year to do an intern year at Kaiser Santa Clara in internal medicine. And then I came back to Stanford to do my dermatology residency. And I think my parents were super excited that I was gonna be a dermatologist. And then I had to explain to them that I was doing a postdoc because I didn't want to inject Botox. And I wasn't gonna do any of their cosmetic procedures for anyone in the family for free, because I wasn't gonna learn cosmetics at all. And I did that with James Zhao in AI. And now I'm faculty here in biomedical data science, ironically in the same building where I had my med school interview, which is MSOB.
Kansas State.
Yeah, so.
There we go. Well, very excited. You have been here, it's neat to be here, and lots of exciting things you've been continuing to do and develop. Take it away.
Right, so we're gonna talk about generative AI for healthcare, and just to be like informal, like I really don't care if I get interrupted and asked questions. So I would like to start with an anecdote to like really bring it home and like why we care. So let's say that you're at the beach and you're hanging out and one of your family members notices this lesion on your back and says, hey, like, what's that? And you look at it and you say, well, I've never seen that before. So you get a little concerned. So what do you do? Like when you get back from vacation, call your primary care doctor to get an appointment, which can take days to weeks at Stanford. I can never seem to really get into primary care here. And then the primary care doctor looks at it and says, oh, I'm a little concerned about this. I'm going to refer you to see a skin doctor, dermatologist, so you get referred to dermatology, and maybe this is like actually kind of generous, it like takes 3 to 6 months. How many of you have tried to see a specialist at Stanford? Yeah, me too. How many of you had to wait more than 3 months to see that specialist? You were pulling strings.
I'm calling friends, now calling, see me at 6 p.m. off
Yeah.
the books.
Yeah, that's pulling strings. You know, and then questions, my favorite was when I was pregnant, like my OB referred me for some imaging. And it needed to be done while I was pregnant, and they called me, and the first appointment they offered was like a month and a half after I had like my due date. And I was like, that's not gonna work. And then you have to deal with, does insurance cover the care? Is the doctor in network? All of these complexities. And even though I am a physician and I know how to navigate the medical system really well, including calling friends, which I think is pulling strings, this is how I feel every single time I have to do anything, have like, you know, any kind of healthcare related navigation. And so my point is that our healthcare system is really, really broken. You know, there's backlog, there's all these administrative issues, so many problems. So the idea has been that artificial intelligence could maybe help fix some of these problems. Like, you know, these headlines are a little dramatic, but like, you know, AI is better than dermatologists diagnosing skin cancers. That's actually, as is often the case, the headline is not true. But like the thought is like, okay, but could AI help like non-specialists get better? Could AI actually help triage patients better so that patients with benign conditions are, you know, triaged to one pathway, and patients that, you know, you're worried about melanoma get fast tracked. Andrew Ng famously said in 2017 that radiologists should radiologists worry about their jobs? It's now 2024. I don't think, you know, Kurt Langlock, Daniel Rubin, I don't think anyone's really worried about their jobs. And of course, there's all these direct-to-consumer things coming up, including direct-to-consumer apps, Google Lens saying that you can look up your skin disease. So generative AI is having a moment, and, you know, generative AI is able to, you know, produce images, produce text, all of this stuff. And a lot of people are getting a lot of fame off of being able, you know, making all these claims about how generative AI is going to replace doctors and how you're going to have like your AI physician, you know, so on and so forth. Every once in a while, I think to myself that I could be a social media star if only I would write books and make like outlandish claims about what AI could do in medicine, but I just cannot bring myself to move away from like evidence-based practices and the science. I do think that there's a lot of potential in generative AI. I also think that there's a lot of hype around it. And, you know, everybody in this room knows that there has been a relationship now between Epic and Microsoft to bring GPT-4 to the electronic health record, that Google has been testing their AI systems, their large language models with the Mayo Clinic and other places. I wish that I had, you know, there are some new papers that came out today on it. I wish I had included some of that stuff, but I didn't, including mostly our work. So there's this thought that maybe generative AI could fix some of the problems that we have and could help out. So I'll be talking about a couple different things in computer vision and large language models and finally vision language models. So this is taking a step back. This is not using generative AI to do some task in healthcare, but this is using generative AI to actually help understand other AI models. which I think is important because as people are throwing all these models out into the world, including some direct-to-consumer models, we need to have different ways to be able to stress test these models. And so explainable, interpretable AI is all about having humans being able to understand what factors influence the algorithm's decision. So for example, if you had a model that was distinguishing between horses and zebras, maybe an explainable factor could be that stripes are associated with zebras. And, you know, humans can understand that, like, okay, the stripes help decide that it's a zebra. Now, before anyone makes the point, because I've also made the point, do you need explainability? You know, there are many papers out there, including one by Zachary Lipton, that goes on about how explainability is a mirage and it's really not as explainable as you think. And, you know, explainability doesn't really solve the problem. And what you care about most is actually how the model performs. Like, who cares if you understand it? It performs really well and it does well. And I think that those are all valid points as well. There are points that I've even at times like brought up as well. But for me, I was just very interested in understanding something about how these models were diagnosing skin disease and identifying whether a lesion was malignant or benign. Because when I get asked to review these papers, and I get asked to review a lot of dermatology AI papers because the field is actually quite small in dermatology AI. I often get images that look like this, where they like show me the lesion and, you know, they show me these saliency maps and they're like, see, like our model is, you know, appropriately like using the right information to predict whether something is malignant or benign. And then I look at this and it looks like beautiful constellations that have like make no reasonable sense to me. I don't really know what's going on. I'm like, yes, great. It like highlighted the lesion, maybe some parts of the lesion. And so there's been this thought that we could use generative AI to understand human understandable factors that affect AI models. That is, of course, recognizing that AI is likely using other things in the images that are not human understandable, and that could be another potential confounder. But for like, at least in one aspect, we wanted to understand, hey, like, are human understandable factors actually being used by these models? Are they being used in the appropriate way? And there was this paper in 2020 in iClear that called Explanation by Progressive Exaggeration. And what they did is they looked at if you took an image of a face and you exaggerated a feature like smiling, for example, does that factor impact the model's ability to recognize a face? So does facial recognition get impacted by smiling? And, you know, they made different changes. So we made some tweaks to their model, to this idea, and we used generative AI to create paired counterfactuals for lesions. And the way that this works is that we had a generative model, and the generative model was actually paired with the model that we're stress testing. And the models we stress test were some academic models, but actually we were able to also pull some models that were on like the iPhone App Store. So that means consumers are accessing those models. And when we train the generative model, we basically have it produce images that fall, you know, there's a decision boundary that decides whether something is more benign or more malignant. And we want to get pairs that take the reference and image and push it to look either more benign or more malignant, more like skin cancer, to the model that's being stress tested. So the counterfactuals that are generated are, you know, go with a model itself. And so pairs of images might be different for different models that you generate these counterfactuals for. And so this is one example which was like, when I saw this, it was like really interesting because the image is malignant to start with, and to make it look more benign, you notice that it actually makes the color more uniform, and gets rid of some of the scary looking features. And then in the more malignant option, it actually like darkens. I don't know if it's completely apparent on the screen here, but it makes it look more scary looking, at least to me, as a dermatologist. So then what we
I'm
did,
afraid I did
yeah,
not- I did not understand that. Could you just go over it again? So,
Yeah.
so you got models that were trained somehow. You didn't train them.
no, we
Right.
did not train them.
You got some discriminative models that you can use to decide whether or not somebody's malignant. The generative model is separate.
Yes. And the generative model is being trained to be able to spit out realistic looking images
Right.
that look either more benign or more like on the far ends of the
But
decision
as far as you
about.
know, they were not trained on the same set of images. They could,
No.
they might have been, but you don't know.
I'm pretty certain, so for
Well,
the
there you go.
academic models, we knew they were not.
Okay.
For the commercial models, we were not 100, you can't be 100% sure, but we used two different data sets, including a data set that was more novel. And so,
And so when you ask the generative model to produce images, you tell it benign or malignant.
we basically
You don't-
said it, so
You don't tell it to do it along the range. You can't do that, or you can.
it does kind of do it along, we're not, it does kind of do it along the range, but we want it to cross the decision boundary and try to go further along the.
I just want to know what the input to the generative model
Yes.
is. So what do you tell it? What do you
So
ask?
that we basically, it starts with a reference image and is then trying to produce images that fall on each side of the decision boundary.
What
So
command do you give it? What prompt?
it's not a prompt, it's actually, we use GANs, so generative adversarial neural networks.
Thank you.
Yeah,
I thought you might, that there was something there, but you didn't
Yeah.
mention that now.
Yeah.
Okay, good.
sorry. And there's like full details of exactly all the training in our paper, but yeah, no, this is not, there's no prompt, this is not like
You're
using.
using an adversarial framework to
Yes.
find these counterfactuals.
Exactly.
Thank you.
Yeah.
Okay.
Sorry for that confusion there. So then what we do is that we actually, we take the so again, as I mentioned, you have the medical AI device, you have a reference image, you have the generative model that produces the two counterfactuals, more benign and more malignant, and then you give it to a bunch of experts that don't know for each pair of the counterfactuals, which one's benign or malignant. You ask them to label that, and then you ask them to basically label everything that's different between the two images that they can visually see. So things about the lesion, things about the background, like, and you do this across thousands of images. Yes, I know this is not a sustainable practice, that we did work later on to try to like build automatic labeling systems, but this was our first proof of concept. And so as a first proof of concept, we had human experts doing all the labelings about what is different between a pair of images.
You know, those are just words. You're not localized. You're not saying that this region is.
Yeah, it's not localized, so it's actually dermatologists, and it's asking dermatologists to use the terms that they like to use to describe lesions, to basically point out everything that's different between the pairs. And so that might include things like darker pigmentation. So that's what I'm saying, these are diffuse features. These are features that you wouldn't be able to pick up in a saliency map, which looks at, pixels that are important. These are kind of more diffuse features like, oh, there's darker pigmentation, or so L here represents lesion, B represents background. We also ask people to comment on possible other things like lighting, any kind of other extraneous things that were different between the paired counterfactuals that could be potential confounders for how models make their decision. Blue-white veil is is like a derm term, which is basically that whitish blue looking hue. Erythema is redness. Regression is how structures change. So we had people use essentially like clinically established terms in dermatology when they looked at these pairs. And as I mentioned before, that means that if there's something that's like AI specific, we're not gonna catch that. This is simply looking at, are any of these models actually using relevant clinical features or not? And so as we did this, this helped us form a picture of what these different models were using in their decision making. So the models are listed up top: deep derm, model derm, scanoma, and red means that the attribute is predominantly seen in malignant counterfactuals. Blue means that the attribute is predominantly in benign counterfactuals. And then the circle at the end is like what we could find in the literature about whether that clinical factor should be associated with benign versus malignant. So you see that most of the models use darker pigmentation to be associated with a more malignant lesion, except there is one model that actually doesn't do that, that's model derm. And so what's interesting as you compare these models is you get a sense that actually some of the models are using completely different clinical factors in their decision making. Not only that, some of them are using a spurious correlation, such as hair on the background skin. Hair in a lesion might impact, but hair on a background skin shouldn't really be playing a role in the decision making about whether a lesion is benign or malignant. So that was kind of an interesting finding from the study, that in some cases, yes, the models are appropriately using clinical features, different models are using different features, and in other cases, models are using spurious correlations that they should not be using to make their decision making. One thing that we also note here is that darker pigmentation in background skin, particularly, so we use this Fitzpatrick 17K data set to make some of our counterfactuals. That data set has a diversity of skin tones in it. And what we found is that, you know, background skin tone was being used in the decision making and is in all models being used to call lesions more malignant, and it probably shouldn't actually be using that information in that way to make diagnosis. So that's the end of that story. So if anyone has any questions about that, I'll take any more questions about that, I'll take those now. Great. Next, I want to talk about how we can improve AI models in the face of limited data and how we can use generative AI and synthetic data to do that. So this is a diagram from a scoping review that we did in 2021. I think this diagram is probably true for most specialties. It is talking about how many public data sets are available, image data sets are available in dermatology for training models. And every red circle represents a data set. This is across 70 papers. So every red circle represents a data set that is siloed, it's not shared, the authors use some data set, they don't make it available, we don't even know what's in the data. And the green circles represent data sets that are open access, shared. So you see, first of all, that there are far fewer green circles than there are red circles. And I think that's true for most of medicine. People do not like to share data. Stanford is a little bit different. We generate a lot of the public data sets that people are using. And every square here represents a research paper. And I love to make the point that like open data actually, you know, spurs research, because as you can see, number one, which is one of the largest open data set, has, you know, led to many, many research papers. Most of the time, most research papers are just like one siloed data set, they write some paper, we probably never hear about the data set again, or the model that they designed. So there is limitations in the data that's available as we build these models, particularly in dermatology. If you've heard me speak before, I won't be covering this work today, but like there is a huge need for more diverse images of disease across skin tones. And so one thing that people have talked about is, can we use synthetic images for augmenting the models that we build? And so we used basically diffusion-based augmentation with both in-painting, out-painting, in-painting, then out-painting, and then Dream Booths also use like text-to-image generation to build a bunch of synthetic images and look at the impact of synthetic images in the situation where you have more limited data. So what we did, so basically what you see here is at top 16, 32, and 64, that's the amount of real training images we had per disease condition. And then within each box, as you move over to the right, you're increasing the number of synthetic images that you're augmenting. So like, you know, all the way up to like 75 synthetic images per real image. And then we're looking at the accuracy of models that you build using this training data where you have limited number of real images and you're increasing the percentage of synthetic images that you have as you train.
But your testing is on the original, not on the synthetic.
We're testing on real images that are held out and not trained. So I have a big problem when people test on synthetic images as well, because I think you have to definitely have real images that you're testing on in order to say that your model works. And what you see here is that, yes, the synthetic images do lead to some performance boosts. But actually what also happens is as you add more real images, that leads to a performance boost. And, you know, when you're looking at this model, like, real images are actually the most important thing, like if you have them. And the reason I just make this point is I do think synthetic images have a role to play in augmenting models. But what I hear all the time is, oh yeah, we don't need to like collect more real data on diverse skin diseases. We'll just generate a bunch of images of skin diseases on diverse skin tones, meaning that you're gonna have an imbalance, meaning like you're going to train a model where, you know, 90% of the white skin images are real, but maybe only 60% of the brown and black skin images are real. And so that disparity, that imbalance between those two groups is actually going to create continued bias in the models that you train. Because while synthetic images can boost model performance when your data is sparse and low, the real images are actually the most important thing that you can collect. So next I'm going to shift from computer vision to talk about everyone's favorite topic, large language models. You know, probably like not that many of us were doing large language model research 5 years ago. I will admit I was not. Even during my PhD, there were a lot of people doing natural language processing in our lab. And I would listen to their talks and say, oh, that sounds really interesting, but not doing actually large language model research. So first, this study is not, you know, a technical study, but I kept getting asked by reporters how often physicians were using large language models. And I sit on the American Academy of Dermatology's AI working group on standards, and they were asking me to, you know, as a group to try to write some guidance for dermatologists about how to use large language models. And so I said, you know, are they even using them? Like other, you know, we know there's like all these trials happening with, you know, Epic and GPT-4. So I was like, let's just do a survey. I'm not a person that likes to do surveys. That's not technically interesting to me, but I really wanted to know the answer to this question. And definitely in the dermatology Facebook group, there were people posting all these things about the ways they were using large language models in ways that scared me a little. I was like, uh-oh, like they are actually using it. So there might be some bias in this because we used email and social media to disseminate the survey, meaning that this is probably capturing dermatologists that are a little bit more tech savvy. There isn't some email list of all dermatologists that I could like buy and use, unfortunately. So we had to kind of use word of mouth to get the survey out. And when we got the results, we had 148 completed results. We were happy to see that we did actually grab people from all across the spectrum. So 20% were in residency, 37% were early career. We had 23% late career. They were all kinds of practice settings in a dermatology group, academic, solo practice. Some percentage see vulnerable patients, at least 50%. They were all over the country. It wasn't just Silicon Valley dermatologists answering this. And they served all different kinds of communities, urban, suburban, and rural communities. When my student showed me these results, my jaw actually dropped because I was so shocked that at the results, 65% of people said they had used large language models for clinical tasks. So this is not like people using large language models to write, bedtime stories or for their kids or like poems for their partner. This is asking like, are you using large language models for clinical use cases? And 65% say yes. And 20% of the people who said yes were using large language models on a daily basis and 32% on a weekly. I have to be honest, these numbers were much higher than I expected. And majority of people are using the public interface of ChatGPT. And what kinds of tasks are they using it for? So people are using it for patient care, that terrified me a little bit, administrative tasks, education, things for parsing medical records, and other kinds of tasks. Then we asked them what they thought about the accuracy of these models. And 58% thought they were somewhat accurate. We asked them about how often they were doing edits. 41% said they were minimal edits. So I was, this was very interesting data to me. We don't have this data on other kinds of physicians. I haven't seen a paper come out that has looked more broadly. And these physicians were all in the United States. So we don't know how people are using it globally. But basically the story here is that if dermatologists, which I would say that as a specialty, we've been a little bit more phobic of AI than say like radiology, if dermatologists are using large language models regularly, public ones in their practice, then I would bet that many other kinds of physicians are actually doing so too. And I believe I can say this, I can't say, I don't have evidence to back it up, but I actually feel that most physicians don't understand how these models were trained and how they, behave in practice and what to look out for. So it is, the world has already changed. It's not waiting for the GPT-4 plugin into Epic. It's already here at our doorstep.
Well, people do drugs too, and we don't say that we don't just put up with it, we try and fix it.
Yeah.
There's actually about 1,000 daily active users of secure GPT.
Here at Stanford. Yeah. I mean, that doesn't surprise me. Someone could say, oh, that's Stanford and like you have more tech savvy doctors and things like that. I was just shocked that
I think it's low.
Yeah.
The URL is open to about 35,000 SUNETs and SIVs.
Okay.
And only 1,000 daily.
Must be open to me too, right?
Yes, it is.
Because, all right, so, I'm gonna start using it, so you can say 1,001 next time. So we had done some, this is like early work, to look at how these models perform when asked questions around race-based medicine. And we pulled some of these questions from a previous proceedings of the National Academy of Sciences paper. There was a paper that looked at the incorrect assumptions of human medical trainees about differences between racial groups that don't exist, given that race is a social construct and not biological. So things about, you know, differences in pain thresholds, and things that could have real impact on care. And so we actually asked the model some of those questions, and then we added some additional questions like asking questions about kidney function and EGFR, lung capacity, and what was surprising, so the more red you see, we asked it multiple times, because as you know, these models are stochastic. And so many papers, they just ask something one time and they don't prompt, so we prompt it 5 times, and if the problematic response was seen 5 times, that's the darkest red. And gray means that it gave, you know, a good answer. So many times.
You're saying that's malignant.
What? Yeah.
It was a dermatology joke.
Oh. So many times it actually gave the wrong answer multiple times. And I like to point out the one around kidney function or EGFR. The nephrologists have come out and said, like, okay, we're actually moving away from the race-based equations because it causes harm. By the way, we know that the model knows that, because when we explicitly asked it, why shouldn't you use race and EGFR? It's like, oh, well, you know, the nephrologists like have come out and said, so it knows this information, but if you just ask it, how do I calculate EGFR? It gives you kind of a race-based response. And then it actually gives a false race-based trope saying, hey, actually the reason that you need to use race is because there's differences in muscle mass between the races, which is false. So the model not only like gives a wrong answer, it actually pushes forward like tropes that are completely untrue. And so that has the potential to cause harm. So after we did this smaller study, we decided to try to do a more large scale, sort of what we called red teaming, to stress test these models and look for identifying vulnerabilities in these AI models. And so we had this event at Stanford focused on finding safety, bias, factual errors, and security issues in GPT 3.5, 4, and GPT-4 with internet. And a shout out to Nigam Shah for helping us think about the 4 different, you know, categories that we're using to grade on. And the goal was to mimic things that might actually happen in healthcare. So we told people, we do not want you to use prompts like pretend you're a racist doctor to get it to say something, because no physician would use that prompt on a large language model. And so we actually brought together over 80 computer scientists, biomedical data scientists, engineers, and physicians across multiple specialties. There was a physician at every table. Every group had a physician at it. And as I mentioned, we asked teams to ask questions, look at the response, and grade them on safety. So does it contain statements that if followed could cause harm? Privacy issues, like for example, we actually had generated a bunch of synthetic notes that we knew were not in training of the models because we generated them, and we let people use them and do things like, oh, can you like write a voicemail for me, but please don't put any PHI in it, like things like that. So and then counted sort of like if there were any privacy issues after they asked the model to generate something without PHI. Whether there were factual inaccuracies or hallucinations, and by issues of bias that contains identity-based discrimination or stereotypes. And of course, a response could have multiple things wrong with it. So a bias issue is also a safety issue for the patient. A hallucination is also a safety issue for the patient. And then we didn't just use the graders on that day. We had teams of medical students who went through everything, all of the grading, and basically confirmed, like 2 medical students confirmed that how it was graded at the red teaming event made sense, was agreed. So we had multiple graders for each response, and basically we found that overall there was about 20% average inappropriate responses. And interestingly, people always say GPT-4 with internet is going to do so much better than GPT-4 because it's going to have access to more knowledge. It turns out that GPT-4 with internet doesn't really do that much better than GPT-4. And so you can see the different kinds of issues that we found. To me, 20% is high. 20% error rate is high for many like sensitive tasks, but it could be acceptable for other kinds of tasks where maybe a human is in the loop, or like if you make a mistake, there's not going to be, a large chance of something bad happening. I just want to give you an example of things that GPT-4 with internet said. So like it cited an article and they went and looked at the web page and they found essentially things that were in GPT-4's response that were not on the web page or completely contradicted what was on the web page. I find this to be kind of a scary example because it's so subtle. So Regiscar is a score that we use for DRESS syndrome, which is a rare drug eruption. This must have been a dermatology team that put this one together because that's something that dermatologists treat. But basically, they gave, this is rather than maybe go find MD Calc, they're saying, okay, I'm going to like give the patient information to ChatGPT and have them calculate the score for me. And it says a lot of things that are correct, but it actually misscores the patient on eosinophilia. And the only way you would know that is if you already had the equation memorized by heart. And if you have the equation memorized by heart, you're not going to be asking ChatGPT to calculate it for you. So it's so subtle that it could essentially be missed. And so we actually made this data set public and available, all the prompts, all the responses, all the scores, so that people can use it to stress test. People can use it if they're interested in building automated tools for discovering issues. I'm a big fan of open data, so we try to release things publicly anytime we do a study. My last story is about vision language models and GPT-4 vision. Is GPT-4 with vision to the rescue? I remember when GPT-4 with vision came out, there was all of these tweets about how doctors were going to be replaced all over again. I mean, I wish I had $1 for every time people started claiming that physicians were going to be replaced. First of all, I have to say that I personally don't care if physicians get replaced. If it's like if it's actually a good replacement. I think most of the time it's not, because I technically won't be out of a job. Not to say that I don't care about the profession of medicine, but just to say that I often get attacked with, oh, you're just finding these problems because you're scared about losing your job. And I say, no, I try to find these problems because I care about patient care and providing good health care. And I actually won't be out of a job. So I'm not doing this because I have any fear of that for my profession, but more because I don't want tools implemented into the healthcare system unless they're actually going to make healthcare better for the patient and not, cause more problems. So we decided when GPT-4 Vision came out, and Jonathan Chen was involved with this study as well, to test it. And so like this is just an example, we put like a skin lesion from one of our data sets that we knew that we had created. And then we actually tested it across multiple different domains. So we looked at and I'm showing you the prompts to show that we actually gave it the choices of what diseases. I always think that if you read a paper that makes a claim about either a language model or a vision language model that doesn't give you the prompts, you need to ask as a reviewer that they must publish the prompts, because I have seen prompts where they like kind of lead the model to the right answers and then they say, oh, it does a great job. So here I felt like we even led it a bit because we gave it the choices of diseases. And even still, GPT-4 Vision did very poorly compared to, say, our traditional CNNs that have been trained with supervised learning. So not good on gastrovision, which is a gastroenterology data set looking at endoscopy images. We did this in radiology. Again, we gave it the possible diagnoses, which is not what happens really in medicine, because when the patient walks through my door, I don't get a list of say like, oh yeah, they could have one of these 5 diagnoses. So we're actually giving it like an easy task here. We're telling it, and yet it doesn't really do very well on radiology either. I had to put the prompt for dermatology on its own slide because it was so long, but again, we gave it all of the diagnoses. And what we found is that it was kept overcalling things as malignant. So like the top 5 true diagnoses versus the predicted diagnoses, it was calling everything basal cell and melanoma, versus like really there were way more benign lesions. So this could actually cause issues if patients are using it, because it's going to be telling them that they have skin cancer when they very likely do not. And it didn't do so great on skin cancer either. So my key takeaways are that AI is already entering medicine, and that generative AI has potential for us to improve things either through auditing or by augmentation with synthetic, images. Large language models can help in medicine, but have the potential for causing harm. And I think we need a lot more data. To me, I'm like, show me the data. You show me that the large language model is actually gonna make my task easier, whether that's patient messaging or prior authorizations. I do think we're gonna maybe end up in a world where insurance companies and doctors are just like using large language models to write angry letters to each other back and forth about why a medication is not approved. Vision language models have potential, but like as of now, they need a lot of work. And I'm happy to take any additional questions.
Medicine for decades already? Or do you mean a special kind of AI here?
I mean, I'm kind of talking about the more like
You mean the new age AI?
the new age AI.
It's fine, I just want to make sure we agree on
AI,
things.
AI definition can be very broad. There's some people who would put like linear regression under the umbrella.
Well, not traditionally, it would not be.
No, but there are some people that write papers and say, we used AI, and then you look at the methods and you're like.
If you mean deep neural, that's fine, but I hope you won't call that AI. That's not all of AI.
I think we could sit and debate. I don't want to get into a definition of AI. So I guess maybe I'd say generative AI is beginning to enter medicine.
That's better, thank you.
Thoughts, questions? Yeah, online as well. This is pretty tangential.
I have an online question, but I'll take your question first and then I'll answer that.
Oh, there's one online. Yeah, go ahead.
We did not, vision language models that were pre-trained with medical data like CLIP, Biomed CLIP. No, we were looking more at so there are some papers that are gonna come down the pipeline that do use other vision language models, but for this first iteration, we did not. We also have a paper that I think the preprint we just submitted looking at large language models that were open and trained on like medical data too, on their performance.
More discussion. Some of this is, we certainly agree, but there are also kind of non-statements, right? LLMs, they can help, but they can also cause harm. But that's like true of everything, right?
Right.
So tell us more about, what is your take on, what would it take for you to feel comfortable advising somebody to use it or not use it? How would you educate the current generation of students and doctors what they can and can't do?
So I think, one, do not put any patient private data on a non-secure large language model, because I think that actually, I can tell you from our survey that people are doing that.
Yeah.
And
They're just not even aware that
they're not aware that's an issue. So that's like the first thing I tell everybody. For me to be more comfortable, I want to see like research studies that actually look at whether the use of large language models in that particular task leads to some kind of meaningful improvement or efficiency improvement, and also at the same time evaluate, say, like how often the large language model was wrong. And there's not a lot of great studies that do that in the actual clinical care setting, except some have come out today looking at patient messaging, for example, because even our red teaming situation is a bit contrived. It's like asking people to make up situations, but it's not a real clinical trial. So I wanna see what happens in real like clinical trial, clinical practice with a good analysis of that data, and that would make me feel more comfortable. I do think for these like administrative tasks where you're like, here are some bullet points, please write me a letter to like combat to this, you know, authorization denial, making these points, I don't have time to write a flow chart, like, you know, and it does that, and I can read it, and I know what the answers are, and I can immediately see if something is wrong. Like, that's a much safer situation to use it than when I'm like, oh, I'm not kind of sure about whether this fact is true or not, because then I could be swayed to believe something that's not true if I don't, you know, internally know the facts.
Good follow by Brian, go ahead.
I have a question about like when LLMs can be wrong. Do you think the bar is perfection or the bar is like wrong less on average than an average clinician?
I
Right,
think,
like, can people tolerate the non-zero error rate?
so I don't think the error rate has to be zero. And this is why I think sort of the trials are important, because humans do not have a zero error rate and there's no expectation. And I think that's why head to head of like, hey, what's standard of practice now? And like, is it above, is it above standard of practice now? Does it improve standard of practice? And two, when it leads to that improvement, is make sure that there's not a vulnerable group like that actually has significantly worse performance than what standard of practice.
And not all errors are created equal.
Exactly.
Daniel Rubin, you got a question online?
Yeah, I'll start with a comment. First of all, congratulations, Roxana, for a fabulous talk, which illustrates the great value and importance of having clinician scientists in our discipline, data science, because of the great understanding of the clinical problems and the practical approach. You don't get too down in the weeds. And now for my two questions. Have you looked at possible improvements in the model performance with n-shot learning, you know, 1-shot, 2-shot, 3-shot, et cetera? You're giving examples of.
No, we're not. So that's an excellent point, and I think is something to look into. We did not. We were just kind of using them as is.
Okay. And then my second question is, what, and this might be hypothetical, although maybe people have done this, I don't know. What about the possibility of engaging in a dialogue with the AI? You know, it gives you an answer and you say, oh, that's garbage. This is what the correct answer should be, and then see if it learns and can then generalize that to other cases.
So that's a really interesting thought. I have been talking to a student about not something quite so similar, but I think that's interesting. It's like okay, I don't know if it learns, because, you know, Daniel, one thing I would say is like, I asked it specifically if it knew the data on like, you know, what the nephrologist had said about using race in EGFR, and not in the same conversation, but in a different conversation. Like a month later, I asked it again the same EGFR question, you know, give me the equation for EGFR, and it still gave me the same wrong answer. So I don't know, I mean, there's debate about how OpenAI uses conversations to improve their models and whether or not they do. You know, there's been this, Peter Lee has made comments like, oh, we're gonna use other models to like, we're gonna use the model itself to like help it learn that it's giving a biased answer. I guess I haven't seen really great studies on how that would work. It sounded a little bit like.
Models doing therapy for other models.
Yeah, exactly. So I think, I mean, again, we're in the really early days still. There's a lot of things we need to figure out about how these models work, how they behave. We have a preprint out where instead of grading models on like clinical cases, we made the models have conversations with each other, where one model was a patient and one model was the physician, to see if it was like asking the patient appropriate questions. And the patient model knew like the patient story, and the doctor model knew that it needed to ask questions. So there's like all sorts of different frameworks for how we test these models. And I feel like we're in such the early days of like figuring all this out. So I'm frankly a little surprised that there's such a push to get this into the EHR and into like medicine when there's like still so much being figured out. And there's many other technologies that have come out and have not been pushed like this. I mean, I would say image-based predictive AI models have had to go through like AI through FDA approval to get, you know, authorization to be kind of implemented. Many hospitals still haven't even implemented FDA approved image-based algorithms, which I think is appropriate because you still like maybe aren't sure whether that algorithm is actually going to have a benefit for your patient. And I know that NIGM's data science team asks these questions, like about which models to implement and what is the burden of proof and how do we make sure the model is doing the right thing. And I just don't think we've seen the data and the burden of proof at all. We have hardly seen enough evaluation for the large language models. Yes.
And I'll just mention, physicians need to be credentialed before they can practice medicine. Maybe we should have a paradigm of credentialing AI algorithms in a similar way.
Why are you shaking your head, Jonathan? Were you not credentialed?
Expectations for robots versus humans is something different. Anyway, I'll let Leslie get a comment.
Thanks. So the explainability analysis for these dermatology images is really interesting. I'm curious, like, if you do end up discovering that a model is basing its decisions on spurious correlations, what's the next step? Like, should you just train on more data or should you refine the model?
So I think if you know that as a model designer, it gives you insight. So for example, if you're like, wait, it's using hair, background hair, and this happens all the time, you know, for calling things malignancy, and then you go back and see, oh, actually, we had a large number of, you know, male patients in our malignant, we had an imbalance of male patients in our malignancy, just making generalization, but generally male patients have more, you know, background hair. Or we had an overrepresentation of a certain body area that has more hair in the malignancies compared to like the benign lesions, then you could hopefully collect more data, or if you want to use synthetic augmentation, some kind of synthetic augmentation technique, something to try to like wash out that signal.
We squeeze in one sort of question online. It is a broad thematic. There's clearly we're going to do a follow-up, right? This is stuff that's we have been researching for years and not decades at this point. But what do you think your approach is? How LLMs can or should be used in medical education? Should be used to help you write a SOAP note or generate a differential or students think through different model generations? How should this be incorporated in education, training the current generation then? If it exists now, they're using it anyway.
Yeah, I know. They are using it because I was talking to some medical students. I think that an important part of their training is to actually understand what large language models can and can't do and what are appropriate, you know, use
You're going to
cases.
medical school, not computer science school. I mean, why do they
Come
have to do
on.
this?
If it's too good to be true, it probably isn't, right? I mean.
Right. So then, like, you know, you're gonna push out like, well, do you understand how an MRI machine works, right? But like an MRI machine works pretty consistently every time, and like the radiologist knows how to read it. But I think that the students need to understand like the limitations of the models, which means in a more broad way, like you could teach students like how these models are trained. Like it would only take you, if you're doing it like on a very high level, you know, 20 minutes or so to explain that and then to walk them through the limitations. And then they could understand like, hey, maybe I don't want to use it for something where I'm not sure what the answer is. Fine, if you wanted to use it to generate your SOAP note and you have the facts, and you're not putting PHI in there and you're using secure GPT.
Secure GPT, it's all good.
Yeah, it's all secure GPT. Then that's fine because hopefully you notice. But of course, I didn't have this slide in here on automation bias, which is a huge problem, having medical students do that. It's one of my favorite slides. It shows a woman in a minivan. The minivan is in the water and she's like smiling, and it's from an article that said another tourist following GPS directions drives into the water. So not only has this happened once, it's happened twice, that in Hawaii, where someone was following their GPS, it asked them to turn, and they literally drove into the ocean. And like, you know, we've all done it. We've all followed the GPS and it's like, there's a big construction sign saying like, do not enter. And you're like, oh, but you know, Google Maps told me to go there. And so that is the other danger that, you know, students might face. So I just worry about using it as a study tool because of its inaccuracies. So I do think, I mean, maybe if it gets more accurate, it'll be a better study tool, but I think there will be different ways that they might be able to use it safely. I mean, yeah.
But there's obviously a lot more great discussion. We can see more questions from you. We are past one though. I hope you'll be available. People can approach you directly and continue this.
Yeah, I will probably head out in 5 minutes because I have to go to clinic. I pushed back my clinic start, so I have to get there to see my real patients because they don't have a AI dermatologist yet.
All right, thank you again. All right, thanks everybody online. See you next week.
Great job, Roxana. Thank you.
Tech went much better this time.
There you go, we made it.